Hello, I'm Shruti Handa. I'm going to talk about orofacial pain conditions that can present as toothache. This is a case of 55-year-old female presenting with toothache lower left molars for the past 2 weeks. Pain started spontaneously. Pain is 7 to 8 on 10 in intensity, constant, throbbing, and feels like a toothache. It is aggravated with chewing and talking, and patient has no sensitivity to hot or cold foods. The dental exam is unremarkable for any dental pathology. However, there is tenderness to palpation of the left masseter area that duplicates the familiar tooth pain. The diagnosis is mascatory myalgia or myofascial pain from masseter referring to the molars. To understand this diagnosis, the clinician should be familiar with the pain referral patterns from mascatory muscles. Like we see in this slide, the pain from the masseter muscle can refer to the upper and lower posterior teeth. Pain from the temporalis muscle can refer to the maxillary anterior and posterior teeth. Pain from the anterior digastric can refer to the anterior lower teeth, and pain from the sternocleidomastoid can refer pain to the cheek and around the eye area. This is another case of a 48-year-old female with right-sided facial pain for the past 3 months. The pain is spontaneous in onset. It is 10 on 10 in intensity, and patient experiences paroxysms of sharp shooting electric shock-like pain, which they are convinced is a toothache. The shocks last for 2 to 5 seconds, and there is no pain between the shocks. They experience several shocks throughout the day. The triggers are eating, talking, brushing, shower, makeup, or even slight touch to the face. There is no sensitivity to hot or cold foods. The dental exam is unremarkable, and the shocks could not be triggered by palpation or percussion of teeth or any of the mascatory structures. The diagnosis is trigeminal neuralgia. Now, the trigeminal neuralgia is a clinical diagnosis, and it can be diagnosed accurately based on pain characteristics alone. It is characterized by sharp shooting pain in the second, third, or the first division of the trigeminal nerve. Sometimes more than one divisions can be involved simultaneously. There can be a constant background pain in addition to the sharp shooting pain in the second, third, or the first division of the trigeminal nerve. The patients can have trigger zones on their face or inside the mouth. These are the areas when slightly touched can trigger the shocking pain. This is a case of 48-year-old female with left-sided facial pain for the past 1 year. Her pain started after an implant surgery to replace tooth number 13. Patient had absolutely no pain before the surgery. The pain was 10 on 10, constant, throbbing, and confined to the implant area. Examination was unremarkable for any dental pathology. Implant was well integrated, and patient had allodynia in implant area and the left cheek area. The diagnosis is post-traumatic trigeminal neuropathic pain. Last case of 28-year-old female presenting with tooth pain, upper anterior teeth, accompanied by headaches for the past 1 year. The pain is intermittent in the upper anterior teeth, 8 and 9, moderate to severe in intensity, and is accompanied by photophobia and phonophobia and headaches, which are usually around their menstrual period. The dental exam is unremarkable for any dental pathology, and the TMD exam is also unremarkable. The diagnosis is menstrual migraines. So, different orofacial pain conditions that can present as toothache includes myofascial pain or pain referral from mascatory muscles, trigeminal neuralgia, painful post-traumatic trigeminal neuropathic pain, neurovascular pain or migraine headaches, and we should not forget about pain referral from sinuses or due to myocardial infarction that can mimic a toothache. Thank you for viewing my presentation. I hope it was helpful in understanding non-dental tooth pain. Thank you.